Good afternoon, all. I am Dr. Rushita from Sri Jayadeva Institute of Cardiovascular Science, Bangalore. Today, I am going to present an intriguing finding in a case of unilateral pulmonary artery stenosis. It's a case is regarding a 12-year-old asymptomatic male child who was sent to us in view of murmur. On examination, his saturations were 90% with wide fixed split S2 and grade 2 by 6 of ejection systolic murmur at left upper sternal border. On X-ray, he had CT ratio of 0.5 with dilated MP and branch PS, and ECG showed right axis deviation with signs of RVH. Echocardiography showed 12 mm of ostium secundum AST, predominantly shunting from left to right with osteoproximal LPA stenosis, 4 mm at origin and 8 mm distally. The gradient across the LPA was 35 mm of HG with diastolic trailing, dilated right-sided chambers and MPA with normal biventricular function. To further delineate the LPA anatomy, we underwent a cardiac CT which confirmed the findings of echocardiography. In view of such discrete osteoproximal LPA stenosis, we planned an LPA stenting. But before doing LPA stenting, we decided to do a lung perfusion scan, so to quantify the blood flows in both the lungs. To our surprise, the lung perfusion study showed the significant hypoperfusion on the right-sided lung. That was only 33% as compared to left-sided lung, which was 67%. To reconfirm such differential unexpected lung perfusion, we decided to do a cardiac MRI, which also showed similar results as lung perfusion scan, 32% on right-sided pulmonary artery and 68% across the LPA with QPQS of 1.1. Being a case of LPA stenosis, we expected that the ipsilateral lung would be hypoperfused, but surprisingly, the contralateral right-sided lung showed hypoperfusion with RV hypertension. We accounted this to long-standing unobstructed flows to RPA, henceforth resulting into an early onset of PVOD and hence the right-sided lung hypoperfusion. We couldn't decide what to do next because there were no such previous case reports or previous such studies in which there was hypoperfusion in non-obstructed lung as compared to an obstructed lung. So we decided to do a CAT study which showed RV pressures of 2/3 of systemic, and hence to reduce these RV pressures, we decided to relieve the LPA obstruction. The other possible favorable outcomes of relieving such an LPA obstruction could be reversing the flow dynamics to improve the flow in RPA, and over a long run can improve the growth of LPA. A pigtail injection in aleocranial view showed osteoproximal LPA stenosis with dilated MPA and RPA. And the measurements were similar to previous imaging modalities. Hence, a 10/30 formula Cook stent was deployed across the stenos segment, and post-stenting, there were good flows seen across the stent. Post-stenting pressure data showed that the RV pressure were reduced to less than half systemic pressures, which were 84 previously, reduced to 50 systolic with EDP of 6. The child was hemodynamically stable post-procedure and hence was discharged on aspirin and sildenafil in view of this segmental pH. Came to us for follow-up. The child was asymptomatic and saturations improved to 96%. ASD was shunting from left to right on echocardiography, and a gradient of 35 mm Hg was found across the LPA origin with minimal diastolic tailing. Child was still on aspirin and sildenafil. We decided to reassess his hemodynamics, and hence the CAT study was repeated, which showed that RV pressure were still half systemic and 20 mm of Hg gradient across the stent. The left lateral view sheet injection showed that there was no discrete LPA narrowing and were good flows across the stent. The measurements of proximal LPA had improved from 4 mm to 9.8 mm and Z-scores from +5 to -0.6. A repeat cardiac MRI and lung perfusion scan was done, which showed similar results as the previous cardiac MRI and perfusion scan. The right-sided lung was found to be hypoperfused, 20% across RPA and 80% across LPA. And the similar results were seen in lung perfusion scan. 26% of perfusion across the right-sided lung and 73% across the left-sided lung. A similar case report was noted in a journal in 2020. A 7-year-old girl, known case of truncus arteriosus, status post-rastally done at 4 months of age, on follow-up was found to have a RPA stenosis in distal branches. A digital subtraction angiography of left pulmonary artery showed more significant pruning in the distal pulmonary vasculature as compared to the right-sided pulmonary artery, which was actually found to be stenosed on follow-up. The previous case report, henceforth we can deduce that a unilateral PA stenosis can lead to contralateral segmental PH. A lung perfusion or a cardiac MRI prior to stenting of such unilateral PS can help unearth such rare pathophysiologies. Early treatment of such unilateral branch PA stenosis can be crucial to prevent the contralateral segmental PH. The role of pulmonary vasodilators in reversing such segmental PH is still unknown and henceforth needs further studies.